All right, guys, let's go over airway management. Just so you know, this PowerPoint is not going to be over every single part of this chapter. You're still going to have to go on jblearning.com or look in your textbook and actually read the fine details. What I'm going to go over is what I believe and what I know are the National Registry EMS standards. Those are the standards that you guys must know in order to become EMTs. So those are the standards that I usually teach to. If you want the full-on PowerPoints, go to JB Learning. They are a lot more in depth. They are a lot more in detail. Mine are just, I wouldn't say broad overviews, but mine are quicker and to the point. So let's get going. Here are some terms that you guys should know for sure. I'm not saying you have to have these memorized now, but I'm just saying these are terms that we are going to use the rest of our career. These are terms that we care about, like cyanosis, the blueness of a skin. That tells us they have no oxygen, but they really need to be ventilated. They might be in shock. And then dead space. That's when we take a breath in, hypothetically speaking, let's say we take in 1,000 milliliters. 1,000 milliliters is not getting to our alveoli. So maybe 850 is getting to our alveoli. So that means we have 150 of dead space. So that's a bunch of air that's going into the body, but it's just not getting perfused by the alveoli. And then hypoxia is just your average insufficiency of oxygen in the tissues. The stoma is the hole, the tracheotomy tube. You guys have probably seen pictures of this, but this is the thing where they have a little plastic tube in their neck, and they breathe out of that. It's a crazy common call for EMTs to go there because the stoma will get occluded with spit or vomit, and the caretaker doesn't know how to care for it, or it's just incredibly dirty, or it gets pulled out. So you guys will run a lot of stoma calls as EMTs. Not typically a life threat, but something you will run a lot of. And then minute volume. Minute volume is probably the most important thing we care about when we are paramedics and we have a vented patient. But for us, a vented volume is how much breath in tidal volumes the patient is getting over 1 minute. So over 1 minute, what is the volume of breath that patient is getting? Now for EMTs, we don't have a way of measuring this. We don't have it. For paramedics and critical care paramedics, we have vents that tell us how much of the minute volume we are inhaling and exhaling. But minute volume is just one of those concepts that please get a really good grasp of it now as EMTs, because it's going to be very important when you go on to become paramedics that you understand what minute volume is. And just rewind, tidal volume is the amount of breath you take in one breath. Okay, so tidal volume is how much air you can take in one breath. That's one tidal volume. You take those tidal volumes times 1 minute, and that's your minute volume. So if you take, hypothetically speaking, each of your tidal volume breaths were 600, and you breathe 10 times for that minute, then that means that your minute volume would be 6,000 milliliters. Nothing that we really need to worry about right now. Just know that down the road, we will need to worry about that when we become paramedics. All right, moving along. COPD. This is something you're going to hear forever and ever and ever. Chronic obstructive pulmonary disorder. COPD is not a specific illness, but yet an umbrella for many illnesses that fall underneath that umbrella that chronically obstruct the pulmonaries. That includes emphysema, asthma, and bronchitis. We're going to go into all three of them in much more detail later on. Dyspnea is just shortness of breath or difficulty breathing. We never really say dyspnea. However, the test questions will always say dyspnea. They're not going to say difficulty breathing. They're going to say a patient displays with significant dyspnea. You guys have to understand that that word means difficulty breathing. Retractions, we see a lot of this in the little kiddos, and this is when the soft tissue underneath your ribs gets drawn up, or underneath your clavicles or above your clavicles. Above your clavicles, they get sucked in because you're trying to exert so much pressure to take a breath in. It's just a sign that we look for that's telling me that they have very much a great deal of difficulty breathing. And then seesaw breathing. That's when the chest rises and then the abdomen falls. The abdomen falls and the chest lowers. And that seesaw breathing back and forth. This is something that we want to assess in the little babies and look for, because that's a sign of significant respiratory distress in those little kiddos. Um, they tend to be nasal breathers or nose breathers, but they don't tend to have the seesaw breathing. Like I said, nasal flaring. Children are primary nasal breathers for the first part of their lives, so check to see if those nostrils are starting to get big. That means they're having difficulty breathing. Pay attention to that. Agonal breathing. This is when that person's about ready to die. This is like those guppy breaths. This is about the time where they're going to start going into cardiac arrest. So this is a horrible sign. If you see agonal breathing, you are for sure going to have to ventilate. You're probably going to have to start chest compressions also. And then tachypnea is just fast breathing. Remember, anything tachy is fast, and pnea is breathing. Okay? Rules. Just always remember this. When you're taking your test, pretty much it's always going to be about the airway. They can't test you guys very much on very many medications or many actions, but they can test you on making sure that airway is open. Okay? The only time when airway isn't a priority is when there's active bleeding. So when you walk up, if somebody had a severed radial artery, you wouldn't have to worry about the airway, because they obviously have an airway because they're talking to you or they're walking up to you. We would go and take care of that bleeding first. Okay? You always must open the airway. I can't begin to tell you how many times just opening up a person's airway with a head tilt chin lift has solved the snoring and then increased their oxygen levels. So something as stupidly simple as just a head tilt chin lift can help open the airway. So fundamental and so basic, and you guys cannot forget that. And then just remember, a jaw thrust is for our trauma patients. Do not use a head tilt chin lift on trauma patients. You'll fail the question. You just can't do that. And just remember, it's always airway, airway, airway. Airway always has priority. And then the review, just the anatomy and physiology, or just the anatomy of the airway. If you look at the larynx, epiglottis, mouth, oral pharynx, nasal airway passage, and the nasal pharynx, that whole little cluster is your upper airway. And then right there at the trachea, the beginning of the trachea is the beginning of the lower airway. So everything in the upper airway is your larynx, epiglottitis, mouth, oral pharynx, nasal air passage, and your nasal pharynx. Okay. Once you get into the lower airway, we're going down to a trachea. Notice it goes down to one tube, and then you go to your carina, where it bifurcates, and that goes from your bronchi into your bronchioles, your main bronchi, and then your main bronchioles, and then they go all the way down to your alveoli. And then down below we have our diaphragm. Remember, the diaphragm is the main muscle of breathing. It is responsible for how we breathe. The lungs are just tissue. They are not a muscle that breathe for us. The diaphragm is the muscle that exerts the pressure to draw in the air and make our lungs do what they do. So the lungs don't do anything without the diaphragm. Very important to remember that. Okay. Here's just part of the upper airway. Just know the upper airway's the whole function, the whole thing is to humidify, clean, and warm the air before it enters the body. This is especially important when we're in pollutants and there's a lot of crap in the air. Our body is designed to filter out all that stuff. If it's cold, it wants to warm up that air, and then also humidify it so it feels like it's close to our body. Okay. The pharynx, as you see, is made up of the nasal, oral, and larynx. No big deal there. You guys have to know this as paramedics, more of the anatomy and physiology, but as EMTs, just know that this is still part of the upper airway. Larynx, also part of the upper airway, right at the very end of the upper airway, but it is the upper airway. And I want you to look at the very bottom of this picture where it says trachea, and it says cricoid cartilage. That cricoid cartilage is the very, very first continuous ring of the trachea. So if you were to push down on that, that actually would not compress the trachea. It would just push it backwards. And so sometimes you might hear some old school paramedics or old school nurses or doctors say they want some cricoid pressure when they're intubating or they're ventilating somebody, and that means that they just want somebody to push down on the cricoid cartilage And in theory, it is to push the trachea down and to make it visible, and then also to occlude the esophagus, so when we ventilate, we don't blow a bunch of air into the stomach, which is not great. And then if you guys look up, for all you guys that want to be paramedics, that cricoid thyroid membrane, that's where we actually cut in with our scalpel if we need to do a surgical airway on somebody who maybe tried to commit suicide and they blew off their face rather than their head, and so they're still breathing but they don't have a mouth. So we have to find an airway, so we create an airway. So that little cricoid thyroid membrane is where we would make that incision and create that hole. Okay, just some more pictures. Nothing too crazy that the EMTs must know right here. Just look at the epiglottis. Okay, the epiglottis. It's the second one up from the right. Just know that the epiglottis, when that gets inflamed, that's called epiglottitis. And epiglottitis, imagine that thing being swollen up and bothered. It's not good. It occludes the airway. It can block it, make you die. It's not very common in adults, but it's crazy common in kids. And so when we get to pediatrics, we'll talk a lot more about that. But if there's anything on this slide that you guys should pay attention to, it's the epiglottis. Look at it, see why it's there. Remember, it's the purpose is it blocks the esophagus when we breathe, and then it blocks the trachea when we eat. It's just that little flap right there. Okay. All right. Once we go down to the lower airway, trachea down to the bronchi, bifurcates at the carina. That carina is that little area where the trachea goes off to the two sides. I cannot begin to tell you how many times I've seen that on a stupid test question, that they want to know that the name of that is the carina, and that's where it bifurcates. Typically, it goes, if you look at it, like if you were looking down the trachea, down to the carina, if like you could look down there, you would see that it actually tilts a little bit to the right. So when we are paramedics, a lot of times we might put the endotracheal tube a little bit too far down, and you might hear the paramedic or the doctor or nurse say, we went right main stem. And that's because we just inserted that tube past the carina and it started to go to the right side. It's just something to pay attention to when you guys are working in the field, or if you intubate somebody in the field during one of your clinicals. They're definitely going to check to make sure that they have lung sounds on both sides. And the main thing they're doing is they're making sure that they don't have a right main stem intubation. But to look back out, review this, your lower airway, where we take our oxygen in. Our oxygen is traded with our CO2 at our alveoli, and perfusion, all that good, beautiful stuff takes place. Okay. Once you get another picture of all this, remember our ribs cover all this. So if a fracture to the rib can fracture anything below that, so pay attention to that. You got your trachea, windpipe, carina. You see your bronchi, your small bronchi, your bronchioles, and then your alveoli with your diaphragm down there. Don't forget the diaphragm is so important. Okay, the lobes of the lung, nothing too crazy here, guys. This one's pretty simple. Just know that there's 3 lobes on the right, 2 lobes on the left. Theoretically, it's because your heart and stuff is on your left-hand side. You guys really don't need to know too much about the different lobes and how they work. Just know that wheezes tend to start upwards, and when you hear those wet lung sounds called rails or crackles, you're going to find those more at the bases at the bottom. Because remember, fluid's always going to go to where gravity takes it. So a main thing with lungs and lobes. 3 lobes on the right side, 2 lobes on the left side. They're surrounded with a visceral pleural. Visceral pleural is, imagine if you, took like a plastic bag that you got at Schnucks or something from the grocery store, and you just wrapped it around your arm. That would be like a visceral pleural, but it's like custom fit for your arm. And in between this custom fit for your arm bag, it's like got a nice little gel in there, so it's very smooth, and it's like a custom fit wrap for your arm. Okay, that's what that visceral pleural is for the lungs. Nothing crazy for us later, but just know that there are instances when that pleural will get infected, or we'll get air in it, or blood in it, and we got to be able to identify that. We can't treat it yet as EMTs, but we can most definitely identify it. Now, these are some three terms that you guys absolutely fundamentally must know: ventilation, oxygenation, and respiration. Oxygenation is just the simple movement of air in and out of the lungs. Nothing crazy there. Now, oxygenation is the actual process of getting those oxygen molecules onto the hemoglobin inside. So that's like getting that oxygen into the bloodstream. And then respiration is when the carbon dioxide in the alveoli do the carbon. Where the exchange between the oxygen and the carbon dioxide in the alveoli, as well as the tissue, takes place. Okay. Oxygenation is the movement of the oxygen onto the cells and into the bloodstream. And then respiration is the actual movement of the perfusion, when we want to exchange the CO2 for the oxygen, and when we want to remove the CO2 from our body and get oxygen. That's the respiration. Ventilation, oxygenation, and respiration. Okay? These are just different things that they call it external respiration, not a term that you guys need to understand. Just know that when we take a deep breath in, it brings fresh air into our body. That fresh air is where the carbon dioxide and oxygen are being exchanged at our alveoli. And then also in our capillaries, like where our muscles are, the same thing is happening down there. I'm sorry, this is just in the pulmonary, not in the muscles. So this is just in the lungs. This is taking place. I apologize. Internal respirations. Now this is where I meant this. This is where I was talking about last time. This is where it actually gets to the cells of the muscles. So this is like making sure that oxygen, carbon dioxide is exchanged in my calf muscles, in your leg muscles, in your arm muscles. This is everywhere else in your body that needs to have that oxygen and CO2 exchange, which is everywhere. So your internal respiration is the body, and your external respiration is basically your lungs. Okay. This is really important to know, is you guys have to know that the chemoreceptors are responsible for how we breathe. So they're basically these little receptors that basically always are looking at, they like have an instantaneous level of the oxygen, carbon dioxide, and our pH and the hydrogen ions in our body. It's like just calculates it. And if one of those goes out of whack, our body wants to go back to homeostasis, which means it wants to go back to normal. So hypothetically speaking, let's say our oxygen is at, I don't know, we'll just say it's at 100%, and our carbon dioxide is 0 because we're sitting down and we're watching TV. But we get up and start exercising, start working out very hard, our carbon dioxide level is going to rise. Now our body wants that carbon dioxide level to theoretically be 0. So anytime that carbon dioxide level rises, it's going to make my body have to breathe harder or faster in order to get all that carbon dioxide expelled and get my carbon dioxide, say, back down to 0. Okay? And the whole thing is being monitored, and in these areas we call the chemoreceptors. These things work 24 hours a day, 7 days a week. They never take a break off. These things are always working, and these are what provide us our rate, rhythm, and quality of our breathing. We don't dictate that. You can sometimes dictate your breathing, but for the most part, when we breathe fast or deep or hard, something is doing it for us. Well, it's the respiratory center, and it's the chemoreceptors that are telling our body how fast and how hard and how well to breathe. Okay, this is a big one. Okay, it's not really fundamental that you guys understand it at a very in-depth level, but you guys have to at least understand what it is. Okay, this is called the ventilation perfusion mismatch ratio, or mismatch. Also told in, you also hear it called the VQ ratio, or VQ mismatch. So ventilation perfusion ratio and mismatch, VQ ratio and mismatch are the same thing. So let's talk about ventilation perfusion ratio, or VQ ratio. When I take a breath in, theoretically all the air goes into my lungs, and theoretically all my lungs should take in that oxygen and use it, perfuse it. Well, what happens if I have pneumonia in my lungs? Well, when I take a deep breath in, the air is going to go in, but in that area where I have the pneumonia, the pus pockets in my alveoli, well, obviously the ventilation is not going to go in there. So there's going to be a ventilation perfusion mismatch, because typically we want to be 100% ventilation and 100% perfusion. But if I'm bringing in 100% ventilation and I can only perfuse 80% of my lung because I have the pneumonia, then we have the VQ mismatch. Okay? Just understand that a VQ mismatch happens. There's no way for the EMT to determine what it is or what's causing it necessarily, but we have to identify things that could cause it, such as you put somebody on a pulse ox and their pulse ox, they look like they're healthy, they're talking like they're healthy, but their pulse ox just won't go above 90. You put them on oxygen and it still doesn't go above 90. You put them on a non-rebreather and it only goes up to like 91%. There is some type of ventilation perfusion mismatch going on there. My guess is probably some type of pneumonia. Just EMTs just need to be aware of that. Okay, so this is our circulatory compromise. This whole big long list of stuff is things that can compromise anything that distributes the blood to our body. Our heart, our blood vessels, or the blood itself, or the lungs. If anything obstructs that, it's going to compromise our circulatory. We got our simple and tension pneumothorax. That's when that visceral pleural around your lung gets filled with air. And that air, it gets so severe that it puts tension on your lung tissue. And then it compresses the heart and starts to push down on it. That's called a tension pneumothorax. That's very bad. That's definitely going to cause a circulatory compromise because it puts pressure on the heart. Open pneumothorax is when you get sliced and you have a cut. Open to your and your lungs are open to the air. That's bad. Hemothorax. Look at that. It's hemo and thorax. So you got blood in the thoracic cavity. And then you got a hemopneumothorax. Holy wow. That's where the blood gets into that pleural lining around the lungs. Then of course you just got gangster blood loss, like old school blood loss. They just lose a lot of blood. Anemia, lack of red blood cells. Hypovolemic shock, so it means lack of volume type of shock, and then vasodilatory shock. Oh wow, look at that big word. And that just means that the blood vessels get really, really wide. Vasodilatory, so your vessels being the vaso, dilatory meaning getting wide. And basically you just go in shock because your blood vessels, rather than being a normal diameter, become very, very wide. And so all the fluid in there becomes very, very low because the container is swelled up so big. Okay, here are the things that we must check for in EMTs, and this is so important. We must identify and treat any and all life threats when it deals with airway. Remember, us homies are oxygen-dependent people, so we need oxygen to live. Always, 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 always assess our airway, our breathing, and our oxygenation. Even 5 minutes, 10 minutes, and 15 minutes into our assessment, we are constantly reassessing the ABCs. Always reassessing them because it can always change. Here's just some normal rates. You guys should pretty much have this, I wouldn't say memorized, but you guys should have an understanding. Infants are fast breathers, 25 to 50. Kids, 15 to 30, and adults about 12 to 20. Okay? Nothing too much we're about to say about that. Here are some signs. If you see this on a test question, if you see any of this on patients, these are signs that these patients, these homeboys, are not getting enough oxygen and they need help. So absent, minimal, or uneven chest movement, absolutely, that's horrible. No air heard over mouth, nose, or exchanges below normal. That's even like, hello, there's no air going in. That's horrible. We need to ventilate that person. Or their noises, such as, these are all bad noises: wheezing, crowing, stridor, snoring, gurgling, and gasping. Gasping means they're gonna die. Stridor is an upper airway obstruction. That's horrible. Snoring, probably just opening the airway will help that. Gurgling, that patient needs suctioning. Wheezing, that person needs probably albuterol. Okay, crowing's probably a kid. These are all noises that as EMTs, we have to understand what causes those noises and what we can do as EMTs to fix it. Wheezing gets albuterol. Crowing with kids, probably humidified oxygen. Stridor with kids, probably humidified oxygen. But what if that stridor is with allergic reaction? Then we have to start thinking about an EpiPen. Snoring, well, is the person lying down? If we sit them up, do they stop snoring? Gurgling, well, what are they gurgling on? Let's clear out their lungs or clear out their mouth and see what that problem is. And then gasping, well, that homeboys have already died, so they just need to be ventilated. Patient looks cyanotic. You'll see a cyanotic person from a room away. And then prolonged inspiration or expiration. Prolonged expiration is the most common first occurring problem with asthmatics. They can get the air in, but they can't get the air out. So you'll notice when asthmatics start having an asthma attack, they have a prolonged expiration at first. As it progresses and it gets a lot more worse, then it will be a prolonged inspiration and expiration. But asthmatics typically start off as prolonged expiration because they can't get the air out of their lungs. And then just look for too fast or too slow. My little mnemonic for that, or my little saying, or whatever you want to say, is less than 8 ventilate. Greater than 28, that's not great. We don't necessarily have to do something, but if they're breathing greater than 28 times a minute, we need to figure out, are they having an anxiety attack? Is it Kussmaul respirations? Is it a head injury? Or are they just breathing fast because they just ran a marathon? Or they just were running because their girlfriend found out they were cheating on them or something? I don't know, but you get my picture. We want to find out why it's too fast or why it's too slow. All right, always assess the airway, like I said. Our thing is to make sure the airway is open. So as for EMTs, we can suction. Once we suction it, we must put in some type of airway, whether it's the oral airway or the nasopharyngeal airway. We must support with ventilation. That means we must ventilate one breath every 5 to 6 seconds. And always, 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 can't express this to you guys enough, especially as EMTs, include oxygenation in our treatment. The number one reason why EMTs will fail is because they forget to put oxygen on a patient during the testing scenarios. Okay? During the testing scenarios, everybody gets oxygen. When you get in the real world, you see it's a little bit different. But for the testing scenarios, they want to make sure that the EMT knows how to give oxygen. So they are definitely going to test you on that. Okay, here's some things that we said. Here are some things we said about the quality of breathing. These are other things we see: chest wall or abdominal movements. Okay, we should not be using our bellies to breathe. That's typically a kid thing. So if an adult is using their belly to breathe, that's a horrible sign. And then we talked about retractions, nasal flaring. We talked about seesaw breathing. And then grunting is actually it's like this really, I wouldn't say it's complex, but just know that grunting is a way to keep the alveoli open. Okay, when they grunt and they go to, and they make that noise, what they're actually doing is creating back pressure in the airway, and they're creating a concept called PEEP, which means positive and expiratory pressure. So it's kind of a way for our body to subconsciously keep our alveoli open when they're prone to getting closed. You'll see this a lot in babies, and you'll see this a lot in old people or difficulty breathing when they're doing really bad. Grunting is just not a good sign. And like I said, grunting is typically a subconscious thing. People don't actively or know what they're doing it for. So pay attention and listen to that. Okay, quality of breathing. So when we always get to our rate, rhythm, and quality of breathing, we want to know, what is their breathing like? Is it normal, or is it all these different wacky patterns? Like if you look at this chain strokes pattern where it goes like short to long to long to short to absent to nothing to short, long, 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 short, absent, it's very fast. That's your chain strokes. And then you got your ataxic, hyperventilation, which is just your anxiety attack. Kussmaul respirations, which deals with your diabetes, and then biots. Our next slide has a better, more diagram of all of these. So here we go. You got your normal breathing up top, And then your ataxic is just irregular, unidentifiable pattern. It's like the AFib of respirations. It's just no pattern. It's just different. It's just irregular, and it's usually because of a head injury. But one, guys, that you guys definitely need to know about is these Kussmaul respirations right there at the bottom. Kussmaul respirations, and if you look over, it's the third one down, and it looks like just like an up and down, up and down, up and down W. That is deep, rapid respirations. And what's so important about that is it is commonly found in people with metabolic ketoacidosis. My picture is covered up thing, and I apologize. But basically, this is very common in patients with diabetic ketoacidosis. So this Kussmaul respirations right here, this is going to be with your patients that have blood sugars about, we'll say 300 or above. All right, so hypoxic drive is just one of those things we need to talk about. As EMTs, we're never really going to be at risk of playing with the hypoxic drive. Okay, remember about 10 minutes ago we were talking about the chemoreceptors and how the chemoreceptors were always trying to get our CO2 level back down to zero. Remember, that's just hypothetical. Well, those chemoreceptors are always trying to get your CO levels back to zero because we don't want carbon dioxide roaming around our body. It's bad for us. Well, what happens to people that smoke for like 20, 25 years, 30 years is after time, their body contains so much carbon dioxide that instead of going back down to zero, their new normal is 3 of carbon dioxide. So now their body just gave it up and they said, okay, fine. We're just going to have 3 parts of carbon dioxide the whole time. And I guess, I'll breathe when it gets to 4. Well, then your body eventually goes, well, it changes it, and it says, well, and instead of that, what we never have is we never have high flow oxygen. We never have oxygen. Our blood stats are never above 92, 93%. So instead of any time you give somebody that's hypoxic drive and you put them on oxygen for a very long time, and their CO2 goes back down to 0, and their oxygen level goes high, they're not going to breathe. I wouldn't say it's a complex thing. Just know that you'll hear more about it when you guys go to paramedic school. It's not going to ever be a part of our treatment as EMTs. And so never, ever, 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 ever withhold oxygen from somebody who needs it. Just know that if you put somebody on a 15 breather, non-rebreather, and they stay on the non-rebreather for a couple days, like 24, 48 hours, then that's when this hypoxic drive can start to kick in. So nothing the EMTs are going to have to worry about. You just have to understand what it is and at least be cognizant that it's out there. Okay? Our treatment for inadequate breathing is the most important thing is open the airway. Maintain it. Maintain it means you provide an oral airway, nasal airway, and you suction as needed. Give oxygen, 10 to 15 liters a minute. If it's a non-rebreather, it's a BVM. Our main thing is to keep that bag full of oxygen. That way, every time we ventilate, we're ventilating with oxygen. We talked about this. The head tilt chin lift is for everybody. Your jaw thrust is for anybody that's a trauma patient. Don't forget to insert your nasal, oral pharyngeal airways, and then we got to know about suctioning. So we have different ways we can give oxygen: nasal cannula, non-rebreather. We have probably all seen those. Remember, nasal cannula is 1 to 6 liters a minute. Non-rebreathers 10 to 15 a minute. And then your blow-by oxygen. This is like when the kids that you try to put them on a mask or nasal cannula, and they want nothing to do with it. So you just have mom hold the oxygen near their mouth. That's called blow-by. It's better than nothing, so it will work. Okay, just know that our non-rebreather is going to give us about 95 to 100% oxygen. Nasal cannula is going to vary from about 22 to 44%, depending on the liters per minute you're going at. I believe if you're doing like 4 liters a minute, I think you're getting like 36% of oxygen. And if you're doing 6 liters a minute, I think you're getting about 44% oxygen. And then we got our positive pressure ventilations, mouth to mask with supplemental oxygen. We'll do that during CPR week. That's where we do our little mouthpiece with the mask. We don't ever really need to do that as EMTs because we will always have the BVM with supplemental oxygen. So that's what we will use. And then the flow restricted oxygenating powered ventilator is like this button you push down and it just delivers oxygen. We really don't see much of it. It's expensive. We don't have one at the school, so you guys don't have to worry about seeing that. I've probably seen it once or twice. I think it's very popular with the scuba divers, so they can get a fresh breath of air. But other than that, we don't use it. End-tidal CO2. This is something that has came about in the past 10 years. It is right now a paramedic skill, but I can guarantee you within 5 years, basic EMTs will be slapping on capnography and trying to obtain this called this end-tidal CO2 form. So just to kind of go over it, I'm just letting you know, look down the bottom where it says normal range is 35 to 45. When we put somebody on CO2 and we're monitoring their breath, we're basically monitoring their exhaust out of their body. So a typical exhaust out of our body is 35 to 45. If it's too high, if it's above 45, there's going to be a reason. If it's too low, there's going to be a reason. And nothing that an EMT must know right now, but paramedics most definitely pay attention to those numbers. And if you look to your right and you see that little thing that kind of looks like a little roller coaster thing, that's actually what it looks like when we breathe out. So if you look at the very bottom, it says respiratory baseline should be 0. That's when we are not breathing. And then the expiratory stroke, that is actually when we start to breathe out. And then the alveolar plateau is as we continue to breathe out. And then at the very end of our breath, when we're done exhaling, obviously that's why it's called the end-tidal CO2, because that's where we get the CO2 reading at the end of that tidal breath. Gives you your number, and then it goes back down, and that's because we're taking, and then you look, the stroke goes straight down, and that's because we're taking a breath in. Now this whole, if you look at the graph, it has a 1, 2, and 3. The shape of 1, 2, and 3 will differ greatly if the patient is having an asthma attack. It will actually look like a shark fin. If somebody's having an anxiety attack, this will look the same. It will just be shorter and shallow because they don't have any difficulty getting the air in or out. They're just taking very short and quick breaths. Okay, lung sounds. I'm not going to actually play the video of this because I don't want to get flagged for it. But just know that wheezes is very common in asthma. These are the patients that needs albuterol. You'll typically hear this in the top of the lungs. Crackles. This is the patients in congestive heart failure. This is because they got fluid in the alveoli. It needs to get pushed out of the alveoli. So when you listen to it, it's going to sound like Rice Krispie treats, or it actually sounds like fluid in the lungs. It's pretty pronounced. This is just respiratory distress. This is what we go on every day of our careers. This is just your typical shortness of breath. So you must know that the difference between respiratory distress, respiratory failure, and respiratory arrest, which we're going to go over in the next 2 slides. So respiratory distress is just your run-of-the-mill, everyday shortness of breath call. They're anxious, they're able to oxygenate, they're able to ventilate, they're able to talk. Maybe they'll only speak a few words at a time, but they're still able to breathe. That's just your basic respiratory distress. Okay. Respiratory failure, this is bad. This is when the oxygen intake is not sufficient to support life. They're still breathing, but they're breathing so poorly that you must ventilate them. Think of heroin overdoses when they stop breathing. They're still breathing, but they're breathing like twice a minute, and their tidal volume is about 200 for those 2 breaths. So that's bad. Those patients must be ventilated. They're in respiratory failure. And then when you get respiratory arrest, remember, anything that says arrest is Not there. So they are not breathing. This is bad. This, if they don't breathe, the cardiac arrest, the heart's going to follow. Obviously, you must ventilate those patients also. One breath every 5 to 6 seconds. High flow oxygen with either a nasal, pharyngeal airway, or an oral airway. Here's our little friend, our suctioning device. Typically, we must have about 300 for adults, 120 for kids, and 100 for infants. That is a very testable question. 300 for adults, 120 for kids, 100 for infants. Only suction on the way out and whenever you see or hear something in the airway. Try not to suction, or absolutely, do not try not to, but do not suction for greater than 15 seconds at a time. Just don't do it. It's bad news. So anytime you hear gurgling in the airway or fluid or any of that, always think about suctioning. Suctioning. When we ventilate somebody, we want to ventilate one breath every 5 to 6 seconds for adults, one breath every 3 to 5 for our kids and infants. And basically, we just want to squeeze it enough to make sure we see the chest rise. So as long as we can get that chest rise, that knows that we got a good ventilation for that one. If the patient's breathing too slow, you'll find this a lot with your heroin overdoses. Put it in a nasal airway. Okay. Make sure you got a good mask and seal. When they take a breath, breathe with them. If the rate is too slow, we're going to breathe extra for them. So they might be breathing 3 times a minute. Well, we're going to breathe for them 5 to 6 times a minute. So we're going to throw in a couple breaths every so often so we can get to 12 breaths per minute. Okay. I can't begin to tell you how many times you guys will do this when you guys give somebody with heroin overdoses, Narcan, especially into the nasal. They're not breathing good as it is, so we will ventilate them for a little bit and help get that Narcan into the bloodstream. And then once it's into the bloodstream, they tend to wake up. But this is a very common, we ventilate a lot of patients because it's too slow breathing. Okay, this is that stoma stuff I was talking about. You see the one up top is an active stoma, and the one little kiddo below, that's an old stoma. But if you look at the one up top to the right, that one looks very clean. Typically, they don't look that clean. They are usually really dirty and filled with mucus and gunk, and that's why the EMTs are there. So the most common cause of obstruction with these guys is just sputum, vomit. I wouldn't say vomit, but spit, mucus. So they need to be suctioned. Kind of gross. It's kind of not my favorite thing in the world. To do. It has some pretty grotesque sounds. It just sounds like someone's about ready to hurl in your face, because it's just a very these people can't clear out their tracheas and their bronchi, so it just has a lot of accumulation of just phlegm, and then when you get it out, it's usually like this massive loogie, and it's just nasty. Okay. Just know that if we can't ventilate these patients, or when we do ventilate these patients, keep their head in a natural position and ventilate over the stoma. You can use like a pediatric mask to form a good seal. And then if, God forbid, that's not working, you can consider sealing the stoma and going through the mouth, but that's probably not going to work. I would just stick with the stoma, suction it really good. That's probably going to be the problem. It's probably going to be clogged with spit. And once you suction it, all it is just a hole with a piece of plastic going into the trachea. So once you suction that out, there's not much else it could be. Okay, kiddos. You guys have to know this with kiddos. By far, the question that they're going to say is the tongue is larger proportions to the airway, so that becomes occluded easily. Cricoid cartilage is the narrowest part of the airway. You have to know that for kids. That's one of those stupid little test questions that they like to ask you. And then just know that they are diaphragm breathers, meaning that it's not abnormal to see them using their belly to breathe. But they should not be using their belly and then their chest, and then their chest and then their belly. If they're using their belly to breathe, that's fine. That's pretty normal with kids. But using that seesaw breathing is bad. Okay, let's talk about some of these conditions for COPD. This is your asthma. Asthma is very common. It can be caused by pollutants. It can be caused by exercise. It can be caused by stress, or it can just be randomly pop up. Okay, so look over at the graph to your right. You see the normal bronchioles, and then look at the one where it says asthma. You see how that tube is just swelled shut? That's what happens with your asthma, is that tube, rather than being able to pass all the air, occludes, and then it gets that little yellow thing in there, and that yellow is mucus. And what's happening is those blue bands that are outside on the red of the tubing, those bands are actually tightening and causing the airway to constrict. And then our body's producing mucus. And all that stuff just sucks and makes difficulty breathing. Okay? If you look at the inflammation, the tube gets inflamed, it swells shut, mucus plugs. These people have a horrible time getting air out. These are your asthmatics. Typically, it starts with expiratory wheezes, and then as it gets worse, it'll be inspiratory and expiratory wheezes. And then when they getting close to dying, it will be you actually listen, won't hear anything because they are so tight, they're not moving any air. So when you listen to lung sounds, you don't hear anything because there's no air movement. And what's crazy about them is when you start treating them, they will actually start sounding very, very bad before they sound better because they have to start actually making noises again as they open up. Albuterol is very common. Albuterol is an example of a meter dose inhaler. Every time they spray that, they're getting their dose of albuterol. It's typically albuterol. It can be a few other drugs, but basically what that drug is going to do is take those bronchioles, those tubes right here that are constricted, and widen them out and make them normal. That's the whole thing of what albuterol is going to do. Albuterol does have some side effects where it makes them a little bit anxious, can also increase the heart rate, but it's worth it. And you'll see the majority of patients who have asthma they call it their puffer, and they take puffs. Now the bad thing is when they call us because they've tried, their puffer is no longer helping them, that tells us, the paramedic, that this patient's pretty sick, and we're going to put them on the same medication just continuously until we get to the ER. When we give the asthma, make sure we got our 5 rights. Our 5 rights will be up in our pharmacology lecture, which is our next lecture next week. The patient must be alert. They put their lips over the inhaler, and then they take a long, deep breath in and absorb as much of the medication as possible. If the patient don't have the inhaler, drive fast, high flow oxygen, and always assess the need to do positive pressure ventilations. Okay? Always assess the need for positive pressure ventilations. That's if your patient doesn't have an inhaler, it's you and an EMT partner, and you don't have anything else, just, they call it a bolus of diesel, and drive fast. Okay, this is emphysema. This is something where this is very common in your older population, like your grandparents, maybe some of your parents if they're older. This is where it's common in people that have smoked or been in areas where they've been around a lot of the pollutants. In your alveoli, they are no longer these nice, picture your alveoli as these balloons that inflate and deflate every single time our lungs expand. And when they inflate, they bring oxygen in, and when they deflate, they absorb the CO2 and all that stuff. Well, imagine those alveoli no longer being really nice balloons, but instead they become these crepit old, like nasty, gnarly balloons that have been stuck outside and left in the sun and have goop and crap all over them. So no, these balloons can no longer inflate and deflate well. Well, that's emphysema. Your alveoli get destroyed. So they no longer have those alveoli, so they have that ventilation perfusion mismatch big time. Their lungs tend to trap oxygen because they no longer have the alveoli, so it gets stuck in there. That's your emphysema. They'll be called pink puffers. And then you've got your chronic bronchitis. Some test questions might call these guys blue bloaters. Okay, basically this is where, if you look at on the right where it says the bronchial swelling, what it's showing you is those bronchial linings are getting narrowed. But then if you were to take a magnifying glass and look at the lining of the bronchial walls, it would look like a bunch of cilia, which is, imagine you're at UPS or Amazon or FedEx, and they got one of those rolly things where they put the package on it and it just rolls it and continues rolling it forward. That cilia is inside your bronchial lining. It's typically doing the same thing with our sputum and our mucus. It's constantly moving it forward so we can spit it out. Well, during chronic bronchitis, that lining gets inflamed. So we have a lot of um, bronchitis. We have a lot of inflammation of the bronchial lining. We have a lot of mucus. These people will spit up a lot. So that's just chronic bronchitis. You'll hear these people. These people have that really nasty, like, wet cough. You guys will hear it a lot when we get to the winter months, but that's usually they're coughing up phlegm. They're usually coughing up something.
Pneumonia is the result of the body's reaction to respiratory
And then pneumonia.
Pneumonia is the result of the body's reaction to respiratory.
I don't want to get that. I don't get that flagged. So let me turn this down. Okay, so pneumonia is just basically when your lungs get to your alveoli, right? That's the area where the lungs perfuse the oxygen to CO2. Well, something gets messed up with the alveoli. Maybe your stomach acid gets in there, or you get some food contents, and the alveoli become destroyed, or you ventilate somebody and they got ventilated way too high and way too hard, and you destroyed the alveoli, or you get COVID-19, and that's just basically like a accumulation of fluid, pus, other organisms at the alveoli, which don't let us perfuse and cause us to have a ventilation perfusion mismatch. Okay, nothing we can do to treat pneumonia as EMTs, but I have always found the most consistent finding with this is you put them on the pulse ox, and their pulse ox will be like 90%. And you listen to their lung sounds, and lung sounds will actually sound fine. It'll just won't sound like there's a lot of lung sounds. Maybe one area, one little low will have a massive pneumonia pocket, and you won't hear anything over that. But until they get a scan and you see where the pneumonia is, it's hard to know. But just know they typically have just continuously low oxygen levels. Even with oxygen applied, people with pneumonia tend to keep their O2 sats pretty low. Sorry. So a pulmonary embolism. Sorry about that. A pulmonary embolism is just an embolism that breaks off and goes into our pulmonary system. So it is a clot. So it basically just a clot that can start anywhere. Usually starts in our legs and ends up in our lungs. So just remember, a pulmonary embolism, out of all this stupid little font and all these stupid little bullet points, which I'm not going to read to you, just know that a pulmonary embolism is a blood clot that ends up into the lungs. And when it ends up in the lungs, it greatly affects the body's ability to have adequate ventilation perfusion mismatch. These people typically complain of a sudden onset of difficulty breathing. They have chest pain, and when they take a deep breath, it gets worse. The pain does. Nothing we can do about it for EMTs. Hyperventilation. Oh man, this is so popular. I won't say popular, but it's so common. We run a lot of anxiety attacks. A lot of anxiety attacks. So we just have to be able to differentiate between hyperventilation and difficulty breathing. One thing that I can always tell you is when they have hyperventilation, they're able to talk in full sentences. Their pulse ox tend to be 100%. They tend to have what they call carpal pedal spasms, where their fingers feel very numb or their chest feels tingly. That's because they're breathing very, very fast. Okay? Try to slow them down and do some box breathing to calm down that breathing and get those numbers or get those symptoms to resolve. CPAP. This is something that is definitely widely implemented in the EMT level. And I wish I had a CPAP machine to show you. But CPAP stands for continuous positive airway pressure. So just break that down. Continuous positive airway pressure. So imagine somebody constantly giving you a little bit of a vent through your mouth. Okay, that's what's going on here. Instead of getting high pressures, we're talking about 7 to 10 centimeters of water extra in our airways. And what's that doing is it helping keeping our alveoli open. we're increasing the airway pressure to keep the alveoli open. Your parents, your grandparents, some of them might have CPAP they use at night. You can put that CPAP on. It's not going to hurt you. It's not going to bother you. You can feel what it feels like. It just kind of feels like a little bit, I wouldn't say a fan, but you just kind of a little blow in your mouth, blow in your nose. Once you get used to it, people breathe so much better. We use it a lot in the emergency setting as EMTs and paramedics for people with congestive heart failure or pneumonia, so we can get those alveoli, the pressure in the alveoli up, keep them open, and then try to get some ventilation and perfusion going on. Okay. As you see, this person right here, this is pretty much what a CPAP mask that we will use in EMS will look like. You have your stupid little machine there, or tube, and then the mask. Now, the mask has to be a really good seal. Like, it can't be loose. It has to be very tight. So that can be kind of anxiety provoking, especially with people who are having difficulty breathing. So sometimes just being able to calm them down and just talk them through it is the best thing you can do. I've had it to where patients have been almost dying, and then once I got them on the mask, they were anxious, but then once they were on the mask for about a minute, they discovered, wow, this thing is starting to help. And by the time they get to the ER, they feel much better. So coaching is big with this. It's kind of intimidating putting a mask on somebody having difficulty breathing. You really have to be empathetic but stern and let them know that this is going to help them. Okay? Be very careful if they have hypotension. Do not use it with patients with hypo blood pressure or low blood pressure. Not good. Okay? This is who gets it. They're able to follow commands. If their pulse ox is below 90% and they have difficulty breathing, we really don't hate on any of the difficulty breathings. If they have difficulty breathing and their pulse ox is low, we're going to try CPAP. They have to be alert. They have to be able to control their airway. Basically, you see that little mask goes on, and then the strap's behind the head. Okay? All right, these suckers do not get CPAP. These people do not get CPAP. There's 2 pages of this. There's actually quite a few people who do not qualify for CPAP. They are ventilating. They are not breathing at all. If the patient can't speak, if they're breathing too slow, they're unresponsive or cannot follow commands. If they can't protect their airway, they got blood in their airway, vomit in their airway, or they have low blood pressure. Cannot use it. Don't use it. You'll kill them. And then no CPAP for these fools. Pneumothorax or chest trauma. They have the tracheostomy. Can't do it for them. They have active GI bleeds or vomiting. They have facial trauma. They're in cardiogenic shock. If they can't tolerate the mask or they can't sit upright, they don't get it. You will see that there will be people that just can't put this mask on. And it's unfortunate because this mask will help them. But there's just going to be people that just will not tolerate the mask. This is pretty much what it looks like right here. The yellow little circle right there is where you put your breathing tube into, and then you put the mask on, and then you see a little knob right there in the middle. It says CPAP adjustments. You basically do that until that little green arrow is between 7 and 10. And you attach oxygen to it. This will suck your oxygen dry rather quick, so you got to be very cognizant of that. All right. That's going to wrap it up. If you guys have any questions, feel free to holler at me at school. Peace.